welcome again for the amazing panelists. And we will have some discussion that I think you've been briefed. I think for the time, I'll have to start with the first one, and I'm going to be passing one mic to you. So, as a leader, I think we've been talking a lot of times for decades and decades, and not to say we're, our age, and we're all still very young. So as a long-standing leader, what is your view of current challenge in terms of Asian mental health and addiction well-being space? And because I know you seem to be hearing yourself 1,000 times, but I want you to be really, don't be shy, be bold, and in 2 minutes, really give a punch of what actually is in here, in this space, and what are the things that we can do today as some of those challenges and solutions as well. So we'll start with Dr. Gary, yes. You're a psychiatrist.
So this is from my over 20 years experience working as a psychiatrist, a frontline mental health clinician. So I think there's a lack of interest and prioritization by funders, managers, and planners. So, for example, I work in Auckland, so Greenland Clinical Centre. I still do a couple of days of clinical work, so I work in a mental health service for older people. But in Auckland, we used to have we have an Asian mental health service. So, unfortunately, when our last psychiatrist, Dr. Sai Wong, our senior colleague, retired, that position never got filled. And I've asked questions, you can only ask so many questions so many times. The answer comes back saying, oh, we're reviewing the position. So for me, that is not prioritizing the needs of Asians in Central Auckland. Rishi, I didn't come to your talk this morning, but what is the proportion of Asian living in Central Auckland?
32%. 32%.
32, but one third. So we should have 1/3 Asian mental health service, or meeting the Asians' needs here. That's my 2 minutes.
Thank you, that's amazing. Yes, that's so real.
Kia ora koutou. Just thank you very much for the introduction, Kelly. Just a quick clarification that I'm an honorary senior research fellow and researcher at the University of Auckland, and I'm also a public health physician at Health New Zealand Te Whatuora, but the comments I'm making today are my own and not on behalf of Health New Zealand. So in answer to your question around the challenges for Asian mental health and addictions, I completely agree with Gary. We don't do enough to prioritise those, and part of that relates to challenges around the data that feeds into policy and service planning. So we tend to focus a lot on data for people that access mental health and addiction services, but as we've heard already extensively this morning, that only captures a small proportion of the mental health and addiction need out in the community for Asian. And actually, if we broaden the lens, also for MELA communities, so if we think of ethnic communities generally, if we focus on service access, we're only capturing a proportion of the need. And as Minister Ducey told us this morning, and as we all know, he's set 5 mental health priorities, 5 targets for mental health and addiction across the sector. 3 of those relate to people who've accessed services, so that needs quite careful consideration in terms of Asian communities, and therefore that means that the priority around prevention and early intervention is really critically important for our Asian and actually more broadly our ethnic communities. Coming back to that service access data, even that data that we do capture and focus on, there are issues around visibility, using Rumi's term. So within that service access data, we tend to focus on that umbrella Asian term, which as Rishi very eloquently talked about, that can actually mask distinct pockets of need within Asian subgroups. And it's also not that meaningful for the populations that it refers to. Like Roshni, I didn't realise that the term Asian referred to me until I started using Asian health data 20 years ago. The other issue is that even beyond using that Asian umbrella term, sometimes we go even further and we completely invisibilise Asian populations and include them in with the European other group. So we completely ignore the need there. So there are a number of issues around that service access data. We also need to couple that, as has already been talked about, with quantitative and qualitative data that captures that community perspective or need, mental health and addiction need in the community, as well as provider perspectives and community voice. All of that really needs to feed into the policy and service planning. The other issue is that refugee and migrant populations are an acknowledged priority group for mental health and addictions, but we don't have high quality data available. We do have some data available through the RBI, but it's not widely available and not feeding in easily to policy and service planning. So for example, my senior refugee and migrant colleagues in commissioning don't have easy access to that data, which clearly is an issue for the money that they do. I'll leave it there.
Thank you, Dr. Suneela. That's amazing. Yeah, all those very valid points. Debbie.
Maybe I agree with people have said here. The lack of focus and prioritisation, and take as example, even at a legislative level in the legislation, there's a focus on Māori Pacific. There isn't a requirement to focus on Asian and other populations. So at a policy, at a commissioning, at a strategy level, at the workforce, research and data, if we look across all of that continuum, given that we represent 17% of the population now, won't see 17% of the resources, equal resources directed at our population and our needs, and to enable us to deliver services that meet our community needs. So.
Definitely, Debbie, yeah. I would love to see 70% of the resource going to our all the Asian service providers. That would be amazing. So, Dr. Carlos.
Right, thank you. So I'd just like to give you a bit of background. So I'm a GP and an urgent care doctor, so I'm particularly right on the front line. So a lot of people come and see us as GPs and urgent care doctors first when they have a health need. And I don't think I can express it as eloquently as my colleague here, Suneela. She gave a very good, massive overview of what's actually going on, so from a much higher level. I'm going to focus more on the community level because that's where I interface with on a daily basis. And I guess looking at, now I can't speak for the whole of New Zealand because I haven't really worked too much in other parts of New Zealand, but solely from the Auckland perspective, I just see that at least where I work, and I'm based in Flatbush, if you guys know, it's in southeast Auckland, very large Chinese population there, also quite a large and growing Indian population too. Certainly with more migrants coming from overseas and also from other parts of New Zealand, you'd be surprised at how many people come from other parts of New Zealand to live in Flatbush just because of the good job opportunities in Auckland, good cultural support and fantastic eateries and things like that. We're seeing a lot more patients from not just Asian ethnicities, but also from the regular population too, who are looking for a clinician that can understand their culture. And when it comes to mental health, this is not like a physical problem, because physical problems, it's sort of like, it's more objective. With mental health issues, often it's quite subjective. And even though I am Chinese in origin, my understanding does not always extend to someone of a different Asian ethnic culture. For example, someone, say, a Vietnamese refugee, or maybe someone from Afghanistan, which I have a few of. Often they've experienced trauma in their home countries that I would have absolutely no idea, no lived experience, obviously, experiencing. And so what they're going through can be, quite alien to me as a health professional who's pretty much grown up in New Zealand. So I think what I'm trying to say here is that we definitely need a lot more funding into providing sort of healthcare services for all these different communities. And for part of that, apart from funding, we also need more workforce development. So we need to attract more Asian people from different ethnic minorities to work in the mental health sector, just because we are, not just in mental health by the way, in primary care especially, because we are currently swamped. And our 15-minute consultations, as you know, that's how the GP model works, we can't do a lot for mental health. Mental health is not a 15-minute consult. It is much more than that. You require patients to come back on a regular basis to address multiple aspects of the mental health. And a lot of my patients are time poor. They're working full time, working multiple jobs, as one of our previous speakers said. They don't have the luxury to come and spend 15 minutes address different issues, and sometimes by then you might have missed the 8 ball. And if we do need to do a referral, who do we refer to? Secondary mental health services are swamped. Sometimes you see that I made a referral the other day to call the crisis team for one of my patients who was acutely suicidal. They said, "Oh, we'll call you back later on." I referred the patient in the morning. They didn't call back. They didn't get a call back until the late afternoon. This is the crisis team for someone who is acutely suicidal. That's how that's how stretched up mental health services are. Now, add sort of a culturally appropriate service to on top of that to manage our Asian patients. You can imagine sort of where we're going here. So I'll stop there. Otherwise, I could go on the whole day.
Thank you,
I'm going to
Dr. Carlos. Yes, you have highlighted a very real important issue of the access issue and those challenges daily for our people. Thank you.
Thanks, Kelly. It's always pros and cons of being the last in the queue.
You agree with everyone?
Plus is that I get so many ideas, but the negative is that all my ideas are already gone. So, but I will
Sure,
still.
you have a different perspective, I know that.
But I will still divide the challenges into 2 categories. One is systemic issues, another is operational issues. So the systemic issues, I would request and challenge the champions who work in the system, who work in the government system, who work at a very good influential systems, influential positions, that the system is not designed to hear us. Put it this way. When our Honorable Minister said we need to make them hear, but the system it's not designed to hear us. Perfect example, everyone else in the panel and the previous speaker has said the data sets. It is not our duty to collect data. It's not an NGO duty to collect data. 2006, 4, 5, if we go back 20 years, we used to say, "Oh, Vishal, you are only 6.8% population. You're still, just be there. It's population-based funding, it's population-based resources." And then 16, 17, oh, it's needs-based, which is good. Oh yeah, we do have needs and population a little bit increased as well. Oh no, still you need to work more on the population. In 2022, 24, oh, we are about 17, 18%, 35% in Auckland. Ethnic population, 22% nationwide. Oh, we got the population. But hey, Vishal, we haven't got the data. Oh, really? You didn't tell us about the data before, and it's not our duty. So that's a systemic big issue. That is the reason why we are invisible in all the government strategies. Then I'll come on to the operational issues and the challenges where we work. We all work, most of us in the room. Which is definitely resourcing, investment, because that is guided by the data. Social and cultural beliefs of within the Asian subgroups is different. We still get people, in a various Asian subgroups, we have lots of populations who do not still resonate with the word mental health. So the word, can we have a synonym of word mental health that resonate with the different Asian populations? Because in South Asian population and in many other East Asian populations, they still do not resonate with mental well-being term, and that's the reason the cultural and social norms are not there. Then the lack of course, culturally and linguistically diverse services, and we can't blame that there are no services because there are no resources. At the end of the day, the system needs to guide the way for an equitable access for all the health services. I'll just stop here, otherwise we have a lot of material to say.
Thank you, Vishal. I think that's highlighted, yes, definitely. It's an urgency of today's summit is putting together to really create that first step to focusing on where we're going as a growing population, the huge gap of all this mental health addiction services. How can we, move the first step and changing some of the challenges towards solution. So I will combine the next 2 questions together for you guys to really think about. So we talk about like people having challenges, stigma, accessing services, all that. which is great highlight from system issue to the front line, you know, the GP are facing every day. That's great. So we park that. I'm sure like my team is making all those notes that we're going to share in the afternoon with solutions with the minister. So the next two question is, so when like people even access those mental health services, addiction services, like our young people, we share a lot of rich journeys that are people speaking perfect English. What are those challenges for people who are carrying a diverse, different baggage of cultures as well? And I mean, when you say that some of those challenges from your scope of work, and what are your visions to make those solutions for the future for mental health in terms of mental health addiction? So if you can have a 2 minutes each for 2 or 3 minutes for having that. Yeah, maybe start from Vishal.
Oh,
You
all
just
right.
wild eyes help.
Okay.
You
I wasn't
have
prepared.
given.
This is another negative side.
Yeah. So you have just given two major challenges. So what are the experience and solutions do you think?
Yeah, I think I would start with the westernized approach of dealing with mental well-being issues applied right across to all populations. One size doesn't fit all. Definitely linguistically, culturally appropriate services is one. But on the other side, e-mental health, for example, very innovative, very good in thing these days. But there are populations, a bigger chunk of population within the Asian population that do not even understand the face-to-face and interactions yet about mental well-being. And we are introducing e-mental health solutions, and we are introducing other innovative solutions to them. So I think the other chunk is not yet ready for those things. So we still need face-to-face interactions, culturally appropriate services for the broader Asian community. E-mental health alone is not the solution. So we would need to have a good balance and mix, and we need to give an option to the clients and to the people to choose themselves rather than we just force them to choose only E. Then of course the costing, it is not publicly funded everywhere. Maternal health, although it comes in the secondary care, but when it comes to the mental health, the mother has to go through a lot of barriers while struggling herself, and by being a migrant family, husband is doing 2 jobs. It's very, very difficult for a struggling mom to navigate the system. Believe me, we working in the system for 20...
Bye, Minister. Thank you so much.
20 years, we still struggle to navigate the system. So I'll just stop here, 5 minutes.
Thank you, Vishal. Yeah, that's a quick solution, some perspective as well.
Okay, so I think from a primary care perspective, I think what we need to do is sort of a multi-pronged approach. I think there's no one-size-fits-all. And as many people have said previously, you know, our Asian community is very diverse, it's very broad, you know, everyone is very different. So what, you know, the plan would be for one particular patient will be very different for someone else, just because they have a different set of experiences, different illness, that type of thing. And I think what we struggle with in primary care particularly is time. Time is a big factor. 15 minutes is not a lot you can do there, and I mentioned that before early on. The other thing too is timely access to services. So if I had a magic wand, I could wave it, my clinic would be what was traditionally known as an IFHC, Integrated Family Healthcare Centre. So basically it's like a supermarket, it's a one-stop shop. It's like a mall actually, you can have all the services in one place. So, and I mean, a lot of what we do as GPs and urgent care as well is we deal with social issues, which in some ways is a little bit beyond our scope, but sometimes we're forced to deal with it because we just don't have timely access to someone who's specialised in that. For example, a social worker. If I could have a social worker on tap in my clinic, they'll be well used, because a lot of the times people present with social issues. You know, they may not be able to have food on the table. They don't know how to because of language issues. They don't know how to call the electricity company when they have issues with power, the phone, internet, that type of stuff. They don't know, a lot of the migrants don't know how to reach the site to catch the bus. You know, all these things that can lead to mental health issues, distress. There could be family issues, altercations between different generations. Often what I see in elderly health was mentioned before, elderly folk looking after grandchildren while their children are actually working full time. Often, in some ways, they're almost treated like a slave because all they do is they look after the grandchildren, take them from school, take them to school, cook for the family, do all the chores, washing and stuff while their children are working, and then there's not much appreciation. That can lead to mental health issues, and often that is not brought up in the family because it's too stigmatizing, there's too much shame to bring it up. But when you talk to them, and you talk about the physical issues, often you can actually get an understanding, actually, your physical issues are fine, we've done all the tests, all the scan, is normal. I wonder if it's actually a somatization issue. You're basically manifesting your mental health issues in a physical way. Often that's very common in Asian culture. We see that a lot. And often, if you're not used to how they present, as a GP from a different culture, you may have difficulty picking up, like, why is this patient coming with chest pain all the time when there's nothing to be found? But I think once you dig deeper, you understand where it's coming from. So, yeah, I don't want to go over time, but basically, yeah, we need better services. We need everything to be under one place so there's easier for patients to access. We need social workers, we need on-tap psychologists, we need health improvement practitioners, and lots of different other allied health professionals that just makes our job dealing with mental health issues, not just for Asian people, but in general, a lot easier. That's all I have to say for the moment.
Thank you, Dr. Carlos. I just want to point out one thing over your saying, because I think the governments and the ministers, the ministries are trying to solve that some of your magic wand issue by access and choice. But the challenge we know from frontline and even from yourself and talking with other people who are providing that service is the population are changing, the demographic population are changing, particularly in Auckland. I'm talking about 32% of the Asian population. But it's still very much mainstream-driven access and choice, which create such challenge. And we're talking about stigma and shame and access issues. Our people have no idea what is access and choice. What's that concept? It's still you bring I hate to say this, but like almost like an American model try to fit in New Zealand. If you don't really accommodate the population with the diversity, like more Pacific, mainstream, even Kiwis are different from Americans, right? And not even saying about ethnic. And so that doesn't really fit. And that's why I think when I read the report, the KPIs wasn't achieved because it doesn't have the right fit. So if we have that magic wand to have that wraparound service, free up the GPs who are not dealing with those social issues and mental health issues, and fund it accordingly to the population that within the localities. That would be amazing, isn't it? So I should stop. It's not my session. Terry?
Yeah, well, the navigating the system is really hard. I mean, what I hear from people on the ground is, and I know this is one of the things that the Minister of Health has highlighted, is how do we bring all that together, all the services that people need access to, because it's not just about a health service, it's about all the social determinants, and how do we coordinate that, and how does, when you work across government, and I have, it's very, very hard to work across different agencies. The other area is the, I was really surprised by this statistic that only 10% of people, Asian people, access the access and choice services, but that's a reflection of what we don't do as people in the system and in the sector, and having a lens and a focus to ensure that all the programs deliver for all of the community, not for people who know how to access services, not for the people who have higher health literacy, and that's a responsibility that we all need to take to ensure that we have measures and targets that focus on our community as well as the rest of the population.
Thanks, Debbie.
So did you say
Suneela?
after 5 minutes battery will go off?
Is it off?
Sure.
I thought that was a non-switch off.
Yeah.
So in terms of the challenges once people access services, at the risk of sounding like a stuck record, if we're talking about people who access services, we are by definition not talking about the people who have mental health need in Asian communities who are not accessing services. But when they do access services, I think we need to consider, as we've talked about extensively, do we have the right services, and are those services culturally appropriate and culturally safe? So if I had Carlos's magic wand, I would address a lot of those data issues that I mentioned earlier, so that we have the appropriate data feeding into policy and strategy and planning, that we can actually acknowledge, the needs of Asian communities and more broadly ethnic communities. So we actually consider them in policy and service planning. So we have that data about access to services appropriately disaggregated for Asian subgroups. We would couple that with data, qualitative and quantitative data from in the community about mental health and addiction need. We would capture the health service provider perspectives, and we would have community voice. And we would have appropriate data about refugees and migrants and their mental health and addiction needs and their service access. And all of that would be feeding into our policy and service planning. That will be amazing. Yeah, it would be. Just very quickly, so, at that point we would hopefully then be having, the appropriate mix of mainstream primary and secondary services. But one of the key enablers to all of that is ensuring that we have strong Asian mental health leadership in the mainstream structures, which we don't have at the moment. As Vishal very eloquently said, our system is not designed at the moment to recognise Asian health needs for mental health and addiction, or even more broadly. And so I'm talking here about leadership both at a national level, but as we move more to regional models of care and service delivery, that we would have health service provider and community voices actually inputting into decision making around service planning.
Thanks, Dr. Suneela. It's amazing, all the wrap up.
Nothing more to say.
You'd like us?
I think we're very good at looking at the deficits, aren't we? But let's look at some of the positives happening right now, because we can build on these positives. I'll tell you three things, and then I'll tell you three things I want to see in my vision. So the three positives I can think of is, at the moment, the mental health service, this is specialist mental health services, is actually working not too bad. Waitlist, if you come into our service, we can see someone within a month. So this is a mental health service for older people. I was in Canada recently. To see a psychiatrist in the public system take months, near a year. So we're actually not doing too bad. I know we're good at looking at the deficit. Our data is actually world-class data. Canada don't collect ethnic information. So I went there first time, 2019, before COVID, and I said, can I analyze your indigenous mental health data? They said, oh yeah, we do collect that, but it's not readily available. In fact, when you look at the CAI, can't remember what that stands for, Canadian Information Health, they don't report ethnic breakdown of their outcomes. So we are doing not too bad, actually. And actually, a lot of the international researchers are jealous of our data sets. The third thing we're doing quite well is we do have a lot of Asian mental health clinicians, including myself. So in our service, myself, I speak Cantonese, born in Hong Kong. We have a Japanese nurse, we have a nurse practitioner speak Mandarin, we have a Korean social worker. What's something can be improved? At the moment, the experience is a hit and miss. So of course, if you get allocated to see May, isn't that fantastic? You get excellent service if you speak Cantonese, if you live in central Auckland. But I don't look after every older person in our service who speak Cantonese or Auckland. So I think we need to be clever about how to spread our workload. In terms of vision, three visions, I want to see new model of care. I don't know what that looks like. Likely to be co-designed with all the leaders here and people with lived experience. That needs to be done, I think. The second thing, I want to see support for frontline mental health workers, clinicians, Asians. In fact, I called Kelly a year ago. I said, I really worry about the Asian mental health clinicians out there, because I do care. and I have an interest in education and supporting clinicians. There's a lot of us out there, but we work in silos. How do we get us working together? And the last thing I want to say is, have more of these meetings. I think this is probably the first time we
it
come
is.
together. So thank you, Kelly.
Thanks, Dr. Gary, and thanks to all the panelists. I think I'll just quickly sum up. I think you guys have highlighted amazing, like probably takes years of, I don't know how many years altogether, probably 100 years of wisdom. And you're still looking young. So it's from the system issue, from the front line, our workforce access issues, the things, how far we have come. I think we must land, I think I love land on positive, and I am very positive. I would not standing here and hosting this events, probably 20 years ago when I just 2005 when I graduated as a social worker. There's even more like nothing. You can't even, find anything. Now we are today, we do mark some histories, launching the suicide prevention resource. Our young people, amazingly share their journey. There will be QRT services, and we got ministers listen to us. We got officials. We'll be having a panel. We are driving the history. We are marking the history, and we are making a difference. And the panel, and your wisdom, and you share your expertise of those challenges and solutions, bring the light of the hope of today. And today is not the first or the last. Today is only the starting point. I think we should drive more of this to holding the government accountable. And we hear that the system is not designed for us. The Minister Melissa was saying, maybe we didn't speak louder. We should cry more harder for them to listen to us, right? So we got to find solutions. We cannot stand any longer for our next generation, for my children, the younger next generation to come to suffer what we have gone through. So we have to find solution today, and we have to collectively, finding that light for the next generation. So without further ado, please put your hands together to thank all the panelists.